an academic health atmosphere where you're thinking about these things all the time. So using the language from those groups also was very helpful. I mean, you don't have to use necessarily slang, and you don't have to use incorrect grammar, but I wouldn't talk to them necessarily the way that I'm talking to you right now. So it's a little bit more conversational in the stimuli that we presented to them. And even in written forms, if we had any sort of magnets, for example, that we developed for people to remind them to do something, the language really just had to be a big focus for us. And then you have to do some preliminary piloting of the materials that you develop. It's not like a laboratory study where you might do some pilot testing because you're developing a new survey and then run into the lab and do research with the survey. You really want to develop the stimuli that you're going to use and then pilot them again to ensure that you got the feedback accurately from the first go-around. Oftentimes what will happen in health settings when you're working with with actual patients, as some of you know, is that you're usually comparing some sort of a treatment or manipulation to some standard of care. So you would normally use that as your control group. So you need to know what that standard of care is before you start developing your materials. So that's just one little side tidbit. There's a lot more preparation that's involved in doing applied work. Again, so you really have to do this preparation and prepare your stimulus materials before you start actually gathering data. So the next slide. So the next thing is just making sure that you conduct the study and that you keep good relations, not only with your participants, but also with your community partners. You can actually, when you work in a community setting and you are respectful of the community partners, people in those community settings will facilitate your work rather than hamper your efforts. Similarly, participants can facilitate your work. You might not realize it, but just being respectful toward people and being helpful to the extent that you can, they can recruit other people for you or tell other people about it. I mean, you're not hiring them to recruit other people, but they can be an advocate for your data collection effort. If you are doing a study that requires any sort of a follow-up, and you don't have these people in a hospital or some sort of institution where they're going to remain, so you can do that sort of follow-up. For example, if you're dealing with people who are high risk, they may be high risk because they are in homeless settings, or they may be high risk because they are in public housing or in community health. Sometimes these groups can be unstable. And so while you might get people's phone numbers to call them, say 3 months or 6 months or even 12 months down the road, a phone call, people's phones get cut off. Maybe they can't afford to pay their phone bill. So you might do a side query about their address. Some people will give you an address. You might ask for a name and phone number and address of their closest living relative.
And what you say is someone who will always know where you are.
That is a good idea, yeah. And in fact, that may be what we say as well. And so what you'll find is the housing situation for these people changes as well. They may get evicted. They may be living in jail at the moment. You just don't know where they're going to be. So one of the things that we also found helpful, and we didn't plan initially in some of these efforts, was going door to door. So sometimes, even though you've delivered a postcard and it came back to you saying that it wasn't deliverable, sometimes neighbors know where somebody is. They might have moved to live with a friend or a family member, and sometimes they leave their address, for example. So it's helpful also to ensure that, of course, you're going to do all the IRB considerations and give people the opportunity to get the data, and Angela's going to talk about that in a minute. But providers also, you should, part of what you're doing is providing them a service and also showing them the benefit of your collaboration by letting them know about the study results. So one of the really neat things is also letting providers know about the practical discoveries that you've encountered. So in some of the work that we've done, we have had people discover that they had breast cancer and they didn't know it before. We've had people discover in colorectal cancer screenings that they have, and actually these are, that they had blood in their urine, so these are very preliminary screenings. And it's important in these settings to work with your community partners so that when you do have these instances of finding a problem, that there's a way to provide, especially for low-income individuals or medically underserved individuals, to provide affordable follow-up for these people. And that's where your community providers' expertise really comes in and their contacts really come in. So this kind of community partner can help not only let you know if the state or whatever programs are available for reduced follow-up screenings, but also for treatments. And in some of the studies that we've done, our community partners had gastroenterologists who would actually do like pro bono colorectal cancer treatment. I mean, it was amazing. So that's one of the incredible upsides of doing this kind of work. Not only do you get to investigate your theories and test them in real populations where there's a lot of noise, but you also get to actually potentially save people's lives. So I can turn it over to Angela or address any questions that people might have.
Well, I think actually, I know, Angela, you have a lot of material put together, so I think probably what makes most sense is we can go to Angela's presentation now.
Sure.
And then I think
yeah, some of it I'm going to be able to skip over because Tamera did a great job of covering some of what I was going to talk about. So if you want to go ahead and put up mine, and, and again, if anybody wants to interrupt and ask a question, please do. So my work's a little bit different in terms of the populations that I work with, but it's amazing the similarity between my experience and Tamera's. So the high-risk populations that I've worked with include you know, intravenous drug users, high-risk adolescents, and so there's just a couple of different issues that come up. And these are sort of the an overview of what I was going to talk about. A lot of that first part Tamera's already done. Why don't we just jump into the next slide. What you'll find with high-risk populations is that oftentimes, because of the nature of exactly what it is you want to study, they end up accessing particular services. So intravenous drug users end up in methadone maintenance. Drug and alcohol dependent individuals end up in drug treatment. For me, a lot of high-risk adolescents end up having contact with the juvenile justice system. So really, whereas when you're doing work, you know, in a college setting, you just need to ask people if they'll be in your study. There's an additional level of access that's necessary in high-risk populations. So you need permission from the people who run these services to be able to work in their setting. And it's not always the person who's in charge of the organization who actually gives that permission. So some of the legwork that Tamera was talking about in terms of these different service settings is figuring out who it is that you need permission from. And it sometimes takes multiple, you know, trees of phone calls. And by the way, I recommend phone calls, not emails. It's easier to ignore an email. To figure out who that person is that you really need to talk to, and being very gracious and acknowledging, you know, that you know, these people you know, are very busy and you very much appreciate them talking to you is key to finding that key person who's in charge. So just keep in mind that that's an additional level that you'll need to go through. Next slide. Once you're there, one of the most important things is to assure them, especially in the settings I work in, people are underpaid and overworked, and they don't have time to add anything else to what they do. So being very clear with them that you will do the work. Your team will have a presence in whatever the setting is, and that your presence will cause no extra work for the people in the setting. And this is both for logistical and financial reasons. Logistically, as I said, they're already busy. Financially, they can't afford to hire anybody else to do the work that you need done. But there's also ethical issues. So, for example, you don't want someone who's in control of whether an adolescent gets to have privileges on the unit, recruiting them to be in your study, because obviously that sets up a situation of coercion. And so you just need to be clear that you want to keep this separate from what goes on for these people, and that you will be the one doing the work. Similarly, you want to make sure that they know that your priority is the people that they serve. You care about these people. There wouldn't be any reason to be there doing the work if you didn't. And so you just want to sort of make that connection that I care about these people too, and that's why I'm here. And most importantly, everything that you do is with the participants' safety, their benefit, and their confidentiality at the forefront. Tamera mentioned control groups, and in a prison setting, for both IRB reasons and ethical reasons, you can almost never have a no treatment control. So you can't give one condition something and give the other condition nothing, because oftentimes they don't get anything in these settings. So we always have to do either attention placebo controls, information controls, something that will give those participants a benefit over and above what they usually receive. Okay.
Can I just add too, if you're going to apply for funding, that funders will, you will get scrapped if you don't have any control for at least attention and time to participants. So you have to at least do something. So a standard of care is typically the minimum.
Yep. Okay, next slide. It's also important, and Tamera touched on this, to talk to the people who are already in that setting about what they think works. So what do they think you should do? If I want to reduce sexual risk behavior in high-risk adolescents, what are their ideas for doing that? And you will find that sometimes they have very interesting and not theory-based and not empirical ideas, but they're the ones who are experts in their setting. And so, they do what they can with not a whole lot of resources, and sometimes their ideas can really enrich the ideas that you have. And then finally, just recognize that you understand that this is not a particularly easy population to work with. So if you go in and say, yes, I'd like to do a study with 100 young people, and I'd like to do it in the next month, and I'm sure I can do this, they're going to laugh at you because they know that that's not possible. And so be aware that it is a challenging setting, and that there are particular issues. Tamera talked about reading level and other issues that you need to be aware of. But also talk about the reward. So what do you hope if you did everything that you plan to do and your study worked perfectly, what will you achieve? What will your program or intervention or study, how will it help the people in that setting? Okay, next slide. Oh, wait, my computer went to sleep. Hold on. Okay, I'm back. Okay, so tips for staying in. Giving back to the organization is really crucial, and what I like to do is give regular updates and progress reports. So if I have a multi-year study, I go back every year and give them an update in person with a PowerPoint presentation about how we're doing with recruitment, in this case, what the kids say about the program. Oftentimes the kids have great quotes and great experiences that really resonate with the juvenile justice setting. One thing that's really key when you're working with especially sort of a complicated organization like a juvenile justice setting or a medical setting, make sure that everyone there has one person that they can call who speaks for the research project. So that could be you, that could be a postdoc, that could be a professional research assistant. It doesn't matter, but it just needs to be one consistent person. What you don't want is to have people calling your lab and talking to somebody who knows a little bit about the project but not really, and maybe you can talk to so-and-so, because again, these people don't have a lot of time to mess around. So having a consistent contact person, and certainly you can have that person, ask you questions or whatever later, but just making sure that the organization has one person they can talk to, I have found has been really nice and really appreciated. And then ask for their feedback. So if things are not going well, they need to know that they can talk to you about it and say, you've been doing the recruitment this way. Really, it would work better for us if you came on a different day. And so asking for their feedback and making them understand that you care about their feedback can be really helpful. And then finally, disseminate your work. And what I mean by that is, when we develop intervention programs for a particular population, we do it with the notion of what will work in that setting. So they don't have tons of time. They can't do 16-session interventions. So we develop brief interventions that can be given in one shot that we can train most people to do. And so at the end of the study, we can actually give them the intervention so that they can do it. Okay, next slide. Okay, so actually working with the participants. If you can collaborate with someone who's worked with this population before, that's ideal. Tamera said, training, piloting as much as possible, not just your measures, but your procedures. When are you going to do things? How is it going to work in the ecology of the setting? Be ready to change that multiple times. And then make sure you understand what your population values in terms of incentives or things that will encourage them to participate. So in addition to whatever the research benefit is, do they prefer cash? Do they like gift cards? Would they rather have food? Things like that. Okay, next slide.
That's good.
And yes, was there a question?
Nope.
Okay, and then plan for the unexpected. So I've just given some examples here, working with adolescents in the justice system, of the things that can come up that you don't necessarily think of ahead of time. So, the fact that the adolescents want money, but in the settings we're in, we're not allowed to give them cash. So we had to figure out how to buy money orders with grant funds, which is a challenge in and of itself. Understanding that our staff actually have to get criminal background checks to be able to contact these kids. So all kinds of those things. But what's interesting about this is that these unexpected things really make you remember why you're in that population. Something that happened just yesterday, actually. We do testing and treatment for STDs in our current intervention study. And we had a young woman, teenager, who did her follow-up assessment. We tested her for chlamydia. She tested positive for chlamydia. But it turns out that she's also pregnant and she's in foster care. And so there's just this myriad of events that starts to happen with, oh my gosh, now how do we find her to treat her? Who do we have, whose permission do we have to ask? Now we have to go to the MD and say, now how do we treat chlamydia given that she's pregnant, and what does that mean? So it's a lot of unexpected things that happen, but it can help you to remember why these kids need your help in the first place.
Wow.
Okay, next slide. Okay, ethical considerations. There's a whole other level of ethical considerations when you're working with high-risk populations. I would encourage you to look at these guidelines from NIH about definitions of high-risk populations. One that people mess up quite a bit is that according to NIH, children is anyone up to the age of 21. So this is different than the age of consent. And just thinking about, well, are these children? That definition can differ depending on who you're talking to. And I've given you the website here to look up all the different guidance for working with vulnerable populations of different types. Next slide. Your own institutional IRB may have more restrictions than NIH. I said or less, but really I keep trying to think of an example of less and I can't. IRBs are always stricter. So your IRB might actually consider even other populations vulnerable, including people of low SES or low educational attainment. Your IRB might have specific rules. So for example, in New Mexico, we wanted to include wards of the state in our intervention sample, and it's the system, really, the state, who can give permission for their participation in research. And the state was fine with that, and NIH was fine with that. The UNM IRB said, no way. If you can't talk to their partner, their parents, they can't be in the study, which I find upsetting. But it is what it is. And just allow lots of time, because these are probably issues that your IRB hasn't dealt with before. In the case of studies with prisoners, they actually have to change the composition of the IRB to review your protocol. So just make sure that you allow a lot of time. Okay, next slide. So these are all kinds of issues that your IRB might have. So things about consenting, how consenting happens, if passive consent is acceptable, what does the assenting process look like if you're dealing with minors. Just do a lot of research ahead of time, and ideally meet with someone from your IRB beforehand so that you can hit all these issues. Okay, next slide. A certificate of confidentiality can be crucial, especially if you're asking sensitive questions. So if you're asking people about illegal behavior, if you're asking minors about even alcohol use, which is actually illegal if you're under 21. If you're collecting sensitive biological data, so we collect genetic data, we do STD testing. A certificate of confidentiality protects both your participants as well as you as a researcher from having to provide information about the people in your study. So what a COC will do is allow you to, if you were subpoenaed and they said, Joe Smith was in your study and we want his data, a COC allows you to say, I'm sorry, I can neither confirm nor deny Joe Smith's participation in my study. And you're done.
Wow.
So it's really a nice thing to have, and they're pretty easy to get. So I've given you the website there, and I'm happy to talk to any of you offline about getting these. I've done it a lot, and it's really helpful. Okay, I think last slide. Okay, so Tamera touched on this. I'll hit on it just real quickly. Don't be a parachute researcher, so don't parachute in, use their population, and leave, because neither you nor any other researcher will ever be able to go back under those circumstances. So ask research questions that are both interesting to you and also give the population something that they care about, something that they can translate into their setting. You want them to feel like you're giving something back to the organization in return for them helping you. And then send them research reports. What I do is I send technical reports that are written in layman's terms, written in a language they can understand. And then I also send published papers because that's kind of cool for them to see papers that were published in journals because of the collaboration. So just keep in close contact with and really give the organization as much information as you can about how the study went. Okay, I think that's it.
Yes, well, great. Thank you, Angela. Thank you, Tamera. We do have some time now for questions. I'm sure you guys have plenty of questions. Shoot, who's got a question? Just jump right in. If you do happen to be muted, just raise your hand and I can unmute you.
Hey, John, can I ask a question?
Yeah.
I really like the idea, Angela, you brought up about having that one hub kind of contact person for the project, for the collaborators. And I was just wondering, is it a problem at some point if that is a postdoc or a graduate student? Do they not have the same sort of connection or get the same sort of respect, or is there any problems of it not being you as the key person in those?
That's a great question. It's interesting because I would say probably 85–90% of the time having a professional research assistant be the contact person works beautifully. And there's that 10% of the time where whoever the person is talking to, they'll ask a question that either the research assistant doesn't know the answer to, or they need a higher up, or they're getting sort of blowback from the organization. And this is what we call playing the doctor card. that's when Dr. Bryan gets on the phone and talks to them. And it's, we all laugh about it, but there's something about that, level of professionalism that seems to work well. And so you're absolutely right that there's a minority of cases where it does have to be, it does have to be somebody higher up in the chain of command on the phone. But even under those circumstances, we've found that it's better to still have that contact person, and then of course they get in touch with me immediately and I call back the person.
Okay.
So yeah, it's a great question.
What other questions? Looks like Kate, you have a question? Kate, are you here? Uh-oh, maybe there's a problem with Kate's audio.
Can we hear me?
Yep, you're here.
Okay, there we go. I do have a quick question, but actually just wanted to add to something that Angela just said as well, which is that I was given some advice that it's good. You often need, as the sort of PI, I guess, to be the contact person when things go wrong in a big way. But I've also been advised that if the doctor person, if we are the ones who are kind of the boots on the ground and we're constantly at the research site, that often can be bad as well, because I guess maybe especially in my case, since I'm fairly young, I think some of the physicians at the hospital where I work would maybe not be taking me very seriously if I was constantly there. So I've been encouraged to have hierarchies of people who are in charge of kind of the day-to-day stuff, and then I deal with the bigger issues. But so that's just one thing I want to throw in there as another maybe perspective. But Tamera, my question actually had to do with your point about brief surveys. We certainly ran into this issue as well, and we managed to sort of dodge the problem. But one of our, the IRB guy actually at our site, was very hung up on the idea of having validated scales for every possible thing we wanted to measure. And I managed to evade the problem, but one of my concerns was that lots of validated scales have 20 items to do something I could ask in one item if I just wrote it myself. So I wondered if you'd run into that issue or anything similar.
I haven't run into people at the particular sites wanting validated scales. I have on different grant proposals, even when you scour the literature and you try to find the best ways to answer things. Sometimes there's not a validated scale, and sometimes the validated scales maybe don't have factor analyses that are published so you can find out what the best items are to measure those things. So yeah, I'm not sure exactly how I would address that with a particular person, I guess, but I would just argue for the face validity and the construct validity of general items and their predictive utility. I mean, just trying to find different ways to assess that validity without having it being presented nicely in an article, for example, or if there's not a factor analysis.
No.
I mean, does that get at your question?
Yeah, it does, and also it's sort of how I ended up dealing with it. I determined pretty quickly that that word validated was sort of a key word for them, but they didn't necessarily know fully what that would mean, and so I ended up just citing previous studies of mine in which I used the same question, even though I had written it myself, and that ended up working. So I did kind of do exactly what you said. I just wondered if in other situations the person might have not been so easily convinced.
Yeah, and it turns out that we've done the same thing. We've cited our own work
so
showing that it's been
predicted.
Sorry?
We've done exactly. I was going to recommend self-citation, especially for IRBs. So yeah, it worked for us too.
Yeah,
these are great tips to know about.
This is not Tamera talking, but my IRB is very wonderful. They're not micromanagers, and so it's been really great to work with them. And the community partners I've worked with, they've been great to work with too. So these haven't been issues for me here in Ohio so far.
Okay. What other questions does anybody have?
I have a question for both Angela and Tamera. Both of you talked about, having a really good communication and relationship with community partner is crucial for the research with high-risk population. But CPPR takes a lot of time and effort and money, and I was wondering if there is any way to work with these populations, especially for new investigators like me, who needs to be productive and have lots of results. And I'm not the stage of developing an intervention there. So looking at maybe the relationship between variable A and B in a high-risk population. So is there any other way to do the research?
Yeah, I can actually speak to that because I started this research as a graduate student with no money. So, and it was my dissertation. So that was a situation where I had no resources. I had to do it quickly, and I had to get results. And, really at the initial stages, it becomes a one-person kind of a job. So, I met with all the, the people who were in charge at the juvenile justice system. I did all those meetings. I did every single interview myself. I was the one who went to the setting every day. So, it can be done. It's a lot of work for you initially. But the nice thing is that once you've done that work, and that study was completed in, I think it was like a total of 12 months start to finish. Once you've done that, that's in some sense your research foot in the door, right? And so that you have those data now, then you can start to apply for small grants, and then you can demonstrate that you've had success in that population and sort of, build on your success. But you're absolutely right that initially you can't do giant. I mean, I did a questionnaire study. You can't do a giant intervention study the first time. And so it's certainly feasible to do smaller projects. It just means it's a lot more of your feet on the ground, doing the work up front.
And it might also matter what your outcome is that you're focusing on. It may be that the research question that you have is something that might be impacted by something that can be found in patient charts. And so getting permission to look at patient charts for a specific time period. So being really focused with your question and knowing what resources are available to you. So we've done follow-up studies looking at patient charts, and that was, even though we were paid to do other research, that was a side study. In some of the more recent work that I've done, where I don't have this huge fancy research team, it's me and a graduate student who's frankly here to get their PhD in human factors or IO psychology. They're really not interested in health per se. So their focus isn't really going to be delving into how do you do this health work and how do you do these health interventions. So having community partners where a lot of that legwork is done, like an outreach intervention, where our focus is getting different kinds of information to people. So how does that happen? Well, when you create the information for people, that was also a team effort and involved community partners. And so we just modified the different kinds of information that people got. And that was, it involved time, it involved intellect, and it involved the collaboration, but it also wasn't us doing all the human work all the time, the human-powered work. So it was really a collaborative effort with all the different partners. So figuring out what community partners you could work with would be really important, and really having as much of a specific question as you can. You don't have to answer all your questions, so start with the little ones, like Angela said.
I have a follow-up question with that. I know both of you mentioned the importance of establishing partnerships. I'm just curious, how open and enthusiastic have you found some of these partners, like agencies or community agencies, to be in terms of collaborating on research and interventions?
So this is Tamera. I found both, again, so I initially started out when I got to Ohio looking at a lot of different places, and it was a difficult thing to find good community partners, because at some point people who were doing some of the health work, at least who seemed like they were doing health work, were really companies doing testing, and their focus was testing drugs for different drug companies, and that was their whole company. It was a middleman sort of company, and I wasn't really interested in that. So when I got to the community health clinic, those people were very willing, and also that's similar to the people in New Haven when we worked with the community health folks there. They were very interested. The public health people in New Haven could care less. They gave us access to their population. They didn't really care about the health issue that we cared about. They didn't care about the study results, so we didn't really do any follow-up with them. In contrast, the people here who do the cancer prevention stuff, well, I should say similarly to the community health people here, the cancer prevention people here, I mean, they're very interested. What is the best thing? And it's really lovely to see the effect of your intervention be implemented in the work that they do every day. And that was a very close partnership. And in fact, the people that I worked with, the primary person, is on a couple of publications that we have for that work.
And this is Angela. I would just echo exactly what Tamera said. It's really a range. I mean, we have, some organizations we've gone to and they've had bad episodes with other researchers, so they don't even want to talk to us because they think we're trying to, pull a fast one on them. All the way to the other end of the spectrum where they just welcome us with open arms and say, we would love you to be working with our population. What can we do to help? So it really, it's a mixed bag. I wish, that there were one consistent answer, but it seems to be very dependent on the organization.
I would imagine probably a lot of persistence would be key in that.
Yes,
case.
Exactly.
And when you find an excited partner, and this speaks to Now's question, when you find an excited partner, many people make, light the whatever work you have to do, whatever the saying is. But, when you find enthusiastic community partners, even though you're going to be doing all the research and you may be doing all the follow-up, there may be something that they're already doing that you can add an intervention to that doesn't affect what they're doing to any huge degree. It doesn't change the way they do their work or add to what they have to do their work, but it can help you answer a research question.
We're actually over time at this point. I don't know if anybody has any final questions that they wanted to get in with either Angela or Tamera.
And John, if you wanted to send an email to everyone afterwards, I know some people have already logged off, but I'm happy to answer any follow-up questions offline too.
Okay, definitely. I will do that. Well, thank you both, Angela and Tamera. I think I've definitely learned a lot of good information here, and hope everybody else did. So I just wanted to say that thank you both for participating and taking the time out of your busy schedule to share this information. And also, you're welcome. You're welcome. It's been fun.
It's my pleasure.
Yeah, thank you.
And also just want to say the virtual Brownbag series will be taking a vacation for the summer, restarting in the fall. So in the meantime, if any of you have any kind of ideas about any kind of future topics for brown bags, we're all ears to hear any kind of ideas, so just don't feel free to contact me, John Optographic Kent State, with any kind of suggestions. And with that, I believe it's over and out for this brown bag. Thanks for joining us for this Social and Personality Health Network virtual brown bag.
All right, thank you. Bye, everyone.
Thank you.
Bye. Bye-bye.
Bye.
Bye.